Hello my dear curious and studious students of surgery, myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Warm welcome again my dear students in my surgery lecture number 52, that is the renal calculus. In this lecture we will learn renal calculus, its etiology, types of the renal calculus, that is the oxalate stones, uric acid or urate stones, cystine calculi, xanthine calculi, indigo calculi, secondary and primary stones, the secondary stones like phosphate stones and mixed stones, treatment, conservative and surgical treatment, PCNL, ESWL, URS, these are the percutaneous methods, and in the treatment part, open surgery like Pyelo-Lithotomy, Pyelo-Nephrolithotomy, all points will cover in this lecture. Now let's start with the renal calculus. Renal calculus means the renal stone or lithiasis is one of the most common disease of the urinary tract, and in our country there is geographically this is the hot country, so the formation of the renal calculus is casual and normal. It occurs more frequently in men than in women, and it whites than in blacks. It is rare in children. It shows a familial predisposition. Urinary calculus is a stone-like body composed of urinary salts bound together by a colloid matrix of the organic materials. It consists of nucleus around which concentric layers of urinary salts are deposited. Dear students, here is a good picture showing the renal calculus, kidney stone in the minor and major calyces of the kidney. There is also the kidney stone in the ureter. Here is a stone in the pelvis. Here is the various types and sizes of the stones. Staghorn calculus is there also. This is the X-ray image showing the radio-opaque calculus on the X-ray image. Now the etiology. The important factors which influence the formation and growth of the uroliths are as follows. First is the hyperexcision of the relative insoluble urinary constituents. First is the oxalate. Through oxalate is the major component of 70% of all renal stones. Cabbage, rhubarb, spinach, tomatoes, black tea and cocoa contain large amount of oxalate. Ingestion of excessive amounts of ascorbic acid and orange juices also increase urinary oxalate excretion. Acquired forms of hyperoxaluria includes pyridoxine deficiency. Calcium. On regular diet, normal urinary excretion of calcium ranges between 200 mg to 300 mg per day. The major calcium inputs are in milk and cheese. Calcium excretion may increase up to 450 mg or more per day. Primary hyperparathyroidism also causes hypercalcinuria. 2/3 of the cases of these patients may produce renal stones of parathyroidism, hyperparathyroidism. Next is the uric acid. Many patients with gout from uric acid calculi, particularly when under treatment, administration of allopurinol also decreases stone formation, and these are the radiolucent stones, uric acid stones. Cystine. Cystinuria is an hereditary disease which is more common in infants and children. Fifth is the drug-induced stones. The long-term use of magnesium trisilicate is the treatment of peptic ulcer has produced radio-opaque silicone stones. Next point of renal stone formation are the physical changes in the urine, which is urinary pH, colloid content, decreased concentration of crystalloids, urinary magnesium or calcium ratio. Next point is the altered urinary crystalloids and colloids. Urinary crystalloids are the oxalate, calcium cystine, uric acid. Urinary colloids are mucin, chondroitin, sulfuric acid. When there is an imbalance in crystalloids and colloid ratio, either there is an increase in the crystalloid level or a fall in the colloid levels, urinary stones may be formed. If there is any modification of the colloids, that is that they lose their solvent action or adhesive property, urinary stones may develop. Next point is decreased urinary output of citrate. And E is the vitamin A deficiency. E point is the vitamin A deficiency. Deficiency of vitamin A in the food tends to induce stone formation in animals. Deficiency of vitamin A causes discommission of the epithelium. The discomminated cells form nidus for stone formation. This is more applicable to bladder stones. Next point is the urinary infection. In about 80% of cases, there is an infection of the urinary tract First, infection disturbs the colloid contents of the urine, so there is a more chance of the stone formation. Second is the infection also causes abnormality in the colloid, which may cause the crystalloid to be precipitate. Third is the infection also changes urinary pH, which helps in stone formation. And D is the infection also causes increases in the concentration of crystalloids, which may under some circumstances produce stone. Next point is urinostasis. Urinostasis provides a fertile field for bacterial growth. It is also causes a shift of the pH of urine to the alkaline side. Stasis also predisposes urinary infection. It allows the crystalloids to precipitate. Next point is hyperparathyroidism. Due to the overproduction of the parahormone, the bones become decalcified and calcium concentration in the urine is increased. This extra calcium may be deposited in the renal tubules or in the pelvis to form renal calculus. Particularly, enough renal calculi are more likely to develop when hyperparathyroidism is mild and prolonged without much skeletal lesions. First, either nidus or nucleus of stone formation, including Randall's plaque. Randall's observed that the initial lesion in formation of renal calculus is erosion at the apex of one of the renal papillae. Calcific plaques are seen on these renal papillae, which were known as Randall's plaques. Randall postulated that when the overlying mucosa is ulcerated, calcification acts as a nidus on to which insoluble crystals deposit to form stones. Now, next point is the types of the renal stones. Basically, the renal stones can be divided into two major groups. First is the primary stone and second is the secondary stones. Primary stones are those which appear in apparently healthy urinary tract without any antecedent inflammation. These stones are usually formed in acid urine. These stones usually consist of calcium oxalate, uric acid, urate, cystine, xanthine and calcium carbonate. Where the secondary stones are usually formed as the result of the inflammation, the urine is usually alkaline, as urea splitting organisms are most often the causative organisms. Secondary stones are mostly composed of calcium, ammonium, magnesium and phosphate. That's why that's called as a triple phosphate. Amorphous phosphates and the ammonium urates may enter into the composition of the secondary stones. Majority of the secondary stones are phosphate stones. Dear students, here is the image on your screen. You can clearly see there are various types of the stones like calcium, oxalate, xanthine, indigo. All types of the stones are seen on your screen. Now this is the types of the kidney stone. Cystine stones is clearly seen, calcium stones, uric acid stones and steroid stones. Now the primary stones, oxalate calculus, that is the calcium oxalate. This type of stone is usually single and is extremely hard. It is dark in color due to staining with altered blood precipitate on its surface. It is spiky, that means it is covered with sharp projections, which cause bleeding due to the injury to the adjacent tissue. This stone is popularly known as the mulberry stone. Due to high calcium content, is cast as exceptionally good shadow radiologically. That is the radiopaque stones. Uric acid and urate calculi. Pure uric acid calculi are rare and not visible in X-ray, not radiopaque. Their color varies from yellow to dark brown. The surface of these stones are usually smooth. Third is the cystine calculi. These stones usually appears in patients with cystinuria. Such cystinuria sometimes occurs in young girls. Cystine is an amino acid rich in sulfur. These calculi are soft and yellow or pink in color. Pure cystine calculi are not radiopaque. Dear students, this is the picture of the oxalate stones. This is the another pictures of the uric acid or urate calculi, and these are the another image showing the cystine calculus. This is also the cystine kidney stones. Xanthine stones, very rare, smooth and black red, deficiency of xanthine. Xanthine calculi, these are extremely rare. These are the smooth, round and brick red in color. Indigo calculi, they are blue in color and are derived from the indican informed by decomposition of the tryptophan in the intestine and found in the urine. Now the secondary stones, that is the phosphate calculus. Majority of these calculus are composed of ammonium, magnesium, phosphate known as the triple phosphate. Such calculus is usually smooth, soft and friable. This type of the calculus usually occurs in infected urine, and so is a secondary calculus. Stone enlarges rapidly and gradually fills up pelvis renal calyces to take up the shape of the staghorn calculus. Triple phosphate usually results from the liberation of ammonium carbonate from urea brought about by urea splitting organism. These stones are usually radiopaque as these contain calcium, but it is also due to its large size rather than density that it is the radiopaque. Second is the mixed stones. Phosphate stones may occur as covering of the primary stone. Such stones are known as the mixed stones. The primary stones is often the calcium oxalate stone. When the urine becomes infected, deposits of phosphates occurs in the rough surface of the calcium oxalate stones. Such stones also occurs in alkaline urine. Dear students, this is the image of the phosphate stones. Now the effect of the stones. The size and position of the stone usually govern the development of secondary pathologic changes in the urinary tract. The effect of the stone on the same kidney are obstruction and infection. Of first, obstruction. The stone lodged at the uretero-pelvic junction or in the ureter may cause hydronephrosis if the obstruction is intermittent or incomplete. When the obstruction is complete, slowly destroy the kidney. Second is the infection. This is a common complication due to the stasis of urine caused by the stone due to its presence as foreign body. Such infection may cause pyelitis, pyelonephritis, perinephric adhesions and even perinephric abscess. The epithelium of the pelvis and calyces in relation to the stone gradually loses luster, becomes rough and thickened. Parenchymal ischemia may be caused by the local pressure due to the stone. Now the effect of stones on opposite kidney. First is the compensatory hypertrophy may occur when the affected kidney has lost function due to the complete obstruction with stone. Second is the stone formation may be bilateral. Third is the infection of the opposite kidney may result from ascending infection from the urinary bladder when urine becomes infected due to the presence of stone. And fourth is the calculus anuria. Reflex cessation of the functions of the opposite kidney occurs due to the renal reflex caused by the complete obstruction of the affected kidney with calculus. Now the clinical features. First, symptoms. Symptom-wise cases can be divided into 4 groups. First is the quiescent calculus. A few stones, particularly the phosphate stones, may lie dormant by quite a long period. During this time, the stones gradually increase in the size with destruction of the renal parenchyma. Such stones may be discovered accidentally in X-ray performed for some other reasons or is first revealed with renal failure or uremia. When the stone is still in the submucosal, that is the Randall's plaque, or adherent to the parenchyma, it may be symptomless. Even Stahon calculus may be asymptomatic. Second group is the pain. Pain is the leading symptoms of renal calculus in majority of the cases, that is the 80%. 3 types of the pain are usually noticed, that is fixed renal pain, urinary colic and referred pain. First, fixed renal pain. If the stone is free and obstruct a calyx and uretero-pelvic junction, there will be a dull flank pain due to capsular and parenchymal distension. Second is the urinary colic. This occurs when the stone attempts to pass down the ureter or temporarily blocks the pelvic-ureteric junction. It is an agonizing pain which radiates from loin to groin. The pain comes on suddenly, during which the patient rolls about, drawing up his knees towards the chest. Tossing on the bed is agony. This colic is often accompanied by profuse sweating, nausea and vomiting. A typical radiation of colicky pain is due to the reflex pain which takes place along the course of the iliohypogastric and ilioinguinal nerve, which are the somatic nerves of the same segment which supply the autonomic nervous system to the ureter, that is from T11, T12 and L1. Sometimes the pain is referred to the scrotum or labium major and to the inner side of the thigh along the distribution of the genitofemoral nerve. When the stone is in the lower part of the ureter, when the stone is in the intermedullary part of the ureter, strangury may occur. Strangury means the painful staining at urination in vein with passage of a few drops of blood-stained urine. Next type of pain in the renal stone is the referred pain. Sometimes pain may be referred to the opposite kidney, which is known as the reno-renal reflex due to the reno-renal reflex. Then the third group of the clinical features of symptoms are divided. The third group is the hydronephrosis. Sometimes patient complains of a lump in the loin and a dull ache, which are due to hydronephrosis caused by the renal stones. And fourth is the hematuria. Occasionally, hematuria is the leading and only symptoms. Hematuria usually occurs in small amount to make the urine dirty or smoky during or after the attack of pain. Now, the physical signs. In majority of cases, characteristic physical signs are not present. The signs which may be present and should be looked for, that is the tenderness. This is mostly present at the renal angle posteriorly. This angle is between the lower border of the 12th rib and the lateral border of the erector spinae muscles. Anteriorly, such tenderness may be elicited about an inch below and medial to the tip of the 9th costal cartilage, which is known as renal point. Tenderness is more a constant feature when renal calculus is associated with infection. And second is the muscle rigidity. Over the kidney may be found in the few cases. Rebound tenderness anteriorly can be elicited, particularly if acute infection is associated with. And the third is the swelling. When there is a hydronephrosis or pyelonephrosis, associated with the renal calculus is a swelling may be felt in the flank. Now the investigations: blood examination, urine analysis like physical examination, chemical examination, microscopic examination, bacteriological examination and renal function test. Third is the radiographs, straight X-ray. At least 90% of renal stones are radio opaque and are easily visible in the plain film of the KUB, kidney, ureter and bladder, KUB region, unless they are very small or overlie bones. It is necessary to differentiate renal stone from other structures and pathologies which may produce radio opaque shadow on straight X-ray. Similar to a renal calculus, these structures and pathologies are as follows. First is the phleboliths, ossified tip of the 12th rib, a calcified lumbar and mesenteric lymph nodes, gallstones, a chip fracture of the transverse process of the lumbar vertebrae, a calcified tuberculous lesions of the kidney, a calcified suprarenal glands, a few drugs, that is the fursulate or foreign bodies in the GI tract. And second is the excretory urograms. Excretory urograms is necessary to accurately localize the calcific shadow in relation to the kidney. It also reveals the function of the other kidney. If the stone is non-opaque, excretory urography will now filling defect or negative shadow. Retrograde urogram may be needed if excretory urography fails to show the kidney due to the poor function. And next investigation is the ultrasonography. This is helpful to distinguish between the opaque and non-opaque stones. It is also of value in locating the stones for treatment with extracorporeal shock wave therapy. Fifth investigation is the computed tomography, that is the CT scan. This is particularly helpful in the diagnosis of non-opaque stones also. And sixth is the renal scan. If excretory urograms shows poor function, isotope studies may indicate further about renal function. Such findings by different isotopes may indicate the need of the nephrectomy rather than nephrolithotomy. And seventh is the instrumental examination like cystoscopy. Renal stone as such does not require cystoscopy for diagnosis, but examination of the stones. Now the examination of the stones. If a stone is passed previously, the crystallographic examination is required in establishing the type of the stones and cause of the stone formation. Now the treatment part of the renal calculus. First we will see the prevention. With more knowledge of stone formation, responsibilities lie on the surgeons to prevent the further stone formation and cannot be left solely to God to prevent recurrence or to fully cure the patient. That's why the surgeon should be try at its level best. Recurrence may be classified into two varieties: false recurrence and true recurrence. False recurrence means a tiny stones were overlooked at the time of operation. True recurrence means a patient with renal stones is usually liable to produce further stones subsequently. The general measures are in this false and true recurrence are: fluid intake should be high at all times, avoidance of milk, cheese and great deal of calcium should be avoided, urine should be kept acid all the times, vitamin D should be stopped. Then the conservative measures: not all patients with renal stones require surgery. When the stones are sufficiently small, these can be naturally eliminated and expectant policy is the best adopted in these cases. In the elderly, poor risk patients or coralliform stone is best left alone unless it causes significant symptoms. Now third is the treatment part of the renal stone is the percutaneous methods of renal stones treatment, that is the development of the extracorporeal shock wave lithotripsy, that is the ESWL, percutaneous nephrolithotomy, that is the PCNL, and nephroureteroscopy, that is the URS, have changed the treatment of the stones to the extent that open surgery is now required in less than 1 to 2% of the cases. Sterile urine is desirable prior to any stone treatment. First, we will see the percutaneous nephrolithotomy, that is the PCNL. First described in 1976, PCNL is a technique which allowed safely and reliably the removal of the stones from the pelvic calyceal system and upper ureter. Complications of this procedure are the hemorrhage from punctured renal cortex is the most common complication, which may be profuse and difficult to control. Sometimes the needle may be perforated to colon or pleural cavity and cause digester. Dear students, here is the image on your screen you are watching. This is the picture of the percutaneous nephrolithotomy, that is the PCNL. You can see there is a fiber optic scope, a renal scope is put into the renal calyx and the becomes polarized and the fragments of the stones is removed through that channel. This is another picture of the PCNL. The surgeon is directly seeing through the lens into the renal pelvis. The stone fragmentation, stone less than 12 mm may be removed intact, but large stones will require fragmentation. This can be achieved in the variety of ways: ultrasonic lithotripsy, that is the USL, electrohydraulic lithotripsy, that is the EHL, laser lithotripsy, that is the LL, and pneumatic lithotripsy, that is the PL. Through these all techniques, the stone fragmentation is done. ESWL, extracorporeal shock wave lithotripsy. In this technique, the stone is removed with shock wave without the need for instrumental penetration of the body. The stone in the kidney is fragmented by the repeated shock waves which are focused towards the kidney stone. The fragments are made so small that they automatically pass through the urine. Darnier HM lithotripter was previously used. Very recently, the second generation of the lithotripter, that is the Lithostar, is being used with this reasonable success. Dear student, here is the image of the ESWL, that is the extracorporeal shock wave lithotripsy. You can see the patient is lying down on the table and the instrument is penetrate and focus the shock waves on the stones, and the fragments made in the small sizes and pass easily. These are the non-invasive techniques. This picture is clearly showing. Now the complication of the ESWL are the ureteric colic, because the fragmentation comes down and there is a chances of the ureteric colic if not processed early. Infections due to the stagnation and obstruction. Ureteroscopy. Next percutaneous method is the URS. In performing ureteroscopy, preliminary cystoscopy in the lithotomy position is carried out and a guide wire is passed appropriate ureter. The ureteric orifice is then dilated with a coaxial dilator. Following dilatations of the bladder is emptied and the ureteroscope is passed through the ureteric orifice guided by the presence of a previously placed guide wire. Two types of the ureteroscopes are available. One is a rigid and second is a flexible. Rigid instrumentation allows for better irrigation with the instrument in the situ. However, flexible ureteroscope allows the better access to the proximal ureter without damaging and the kidney where a rigid instrument are unable to negotiate. This is the drawback of the flexible ureteroscope. Dear student, here is the image. You can see there is a flexible ureteroscope has been used for the ureteric stones and the basket used for to remove the ureteric stones. This is the ureteroscope. You can see it is convenient directly for irrigation to operate on the ureteric stones. The fourth method is the surgical method, that is the open methods. Choice of the technique is the Pyelo-Lithotomy, that is the removal of the stone through an incision on the pelvis of the kidney when the stone lies within the pelvis. Nephrolithotomy, that is the removal of the stone through renal parenchyma, is practiced when the pelvis is mostly intrarenal. Pyelo-Nephrolithotomy, that is the removal of the stone through the both of the pelvis of the kidney and through the renal parenchyma. Partial nephrectomy, that is the removal of the whole kidney, and nephrostomy, that is the simple drainage of the kidney with removal of the calculi, should be operated. Operation of the choice is grossly infected cases. This is the open surgery. The renal pelvis is open. Pyelo-Lithotomy is there, clearly seeing the stone in the renal pelvis. This is the Nephrolithotomy, the stone in major calyx. You can see this is also the Pyelo-Nephrolithotomy. The images of the nephrolithotomy. This is the text picture of the renal pelvic calculus, Pyelo-Nephrolithotomy. Dear students, to clear your concept regarding the renal calculus and its management and treatment and all the points, you can refer a good textbooks available in the market. There is a good videos and animated videos on the YouTube. You can watch it to clear your concepts. Here is the end of our surgery lecture number 52, that is the renal calculus. Thank you.